findings in the cerebellum. It was a paper by Marty Teicher in Ruth's first book on trauma as an epidemic. And he and Carl Anderson were talking about how there was excess blood flow in the vermis, the central structure of the cerebellum. So I looked up where that is in the brain and put the electrode there at the Indian Ridge. And in fact, it seems to have been quite useful at very low frequencies in helping people move out of the PAG, the threat position, in developmental trauma, the fearful position. The subtitle of my book is Calming the Fear-Driven Brain. Whether it was the cerebellum I'm reaching or the brainstem I'm reaching, it's a little hard to know. But what we do know is that they're calming down. Deep brain reorienting, which is showing very positive results in the brain, is a lot of it's affecting the cerebellum. And also the temporal parietal junction, which is a part of the brain, which is a hub. And it shows up in derealization, depersonalization, dissociation, out-of-body experience, feeling you're not real, all of the things which are a concern to people with developmental trauma. We are moving our attention, our interest, we as a group anyway, within EEGer, to the back of the head and to seeing what we can do to quiet reactivity where it begins.
Sebern, thank you so much for being part of this conversation once again. I always gain so much from our conversations in terms of clarity and insight about the work that we're doing, its impact on people in the world, and really inspiration for these are times that really we crave inspiration above all, of knowing that there is some light at the end of the tunnel, and it's not an oncoming train, as Patty would say. So I thought maybe we could start with some of the when you opened the Trauma 24 conference in October of last year, you started with some statements and some ideas by way of introduction. And one of the ones that I wondered if you could just kind of expand on it a little bit. You said that for a lot of us, we found that talk therapy and even neurofeedback are top-down approaches, and that these do not access the kind of transformation that really is not only needed but is possible, and that DBR, in particular, deep brain reorienting, can access them as a more of a bottom-up process. And I wonder if you could describe for me sort of what you mean by that difference between top-down and bottom-up.
Well, let me begin by thanking you for having me in this conversation. I like them too. The assumption has that in all psychotherapies, that we were working from the top down. We were working to either strengthen the cortex, the prefrontal cortex, or to we're speaking to it. We were in the cortical domain, in the cognitive and cortical domain, and that's all cognitive therapies, behavior therapies, all reside in that. But almost all psychotherapies, even analytic therapies, suggest that by talking, we can get to the problems. And that doesn't seem to be the case, particularly in developmental trauma. Neurofeedback has also, for the most part, for most of the time it's been around, has been focusing on stabilizing the cortex and not the subcortical domain of the brain. I don't think that's a necessary prejudice, but it's just where we began in the practice of neurofeedback with C3 and C4 and C2. I think that with the Alzheimer's, we went further down, went into the temporal lobes and started to get to the subcortical areas that way, but not, it would appear, to the brainstem. Ruth Lannis's work actually her research on neurofeedback was on alpha down. And there she showed a powerful effect on the brainstem, actually, that it is how she started to conceptualize what neurofeedback could do. And in that case, the connectivity issues in the brain of people with developmental trauma were from the PAG, the periaqueductal gray, the threat detector in the human brain, to the amygdala. So that was the circuitry that people were living with. The brainstem to the limbic system, which is an excitable, repetitive system, and there's no room for thought. There's not even much room for a sense of having a body or self. So 80% of the people that did this one session of neurofeedback after one session showed in fMRI changes in the PAG, that the prefrontal cortex, the prefrontal cortex was now affecting the PAG, was helping to quiet the PAG, the threat detection. So instead of threat detection taking over, the cognition or the being of the person, the being of the person, the cortical structure was able to shut down the PAG. Now comes along DBR, and I think that deep brain reorient, I was very skeptical about neurofeedback when I first learned. I was very skeptical about DBR. Maybe my skepticism is an absolute measure of what's going to work, but nonetheless, whatever. The whole idea of DBR is a focus on shock, and it's shock as it's retained in the brainstem, and we can get to that through this process called deep brain reorienting. It's a challenging therapy, and not everybody can do it, but not everybody can do neurofeedback either. So it's my interest in it is that I found it to work, and I think the shock hypothesis is absolutely true. I don't think we get to the shock with neurofeedback. I think we get to the aftermath of the shock with neurofeedback. So that's why I want to put these two therapies together.
That makes sense. And the way that I'm thinking about that, I think there's a couple of pieces that about approaching DBR and brainstem therapy or brainstem, these therapeutic approaches that talk about the brainstem, that I think like are very simple in their terminology, but really challenging to understand. And I think part of it strikes me that like when we're talking about the sort of top-down, the thinking, the talk therapy kind of approach, it's very much a consciousness kind of a thing. It's all happening on the level of like, I understand. And in particular, it's about the narrative, right? And the affect. Am I getting that right? Whereas
complexity, essentially, yes.
Okay. And so really what DBR, the whole shock hypothesis, as you called it, is saying is that there are things that are happening when trauma happens that that sort of happened before that affect and that narrative kick in. That's what that shock is, right? Is that there is this, and if I understand what I've heard so far, the idea is that there's actually, we can locate it in the brain. It's the locus coeruleus, right? Which is actually the place that actually registers that shock immediately. And it's only temporary, right? Am I getting it? Am I getting this? And yeah. So then there's the second part of it, which is the orientation. And I think that's the other part of it that's really challenging about this therapy, that then this is positioned in the brain, the way that Dr. Corrigan talks about it, in the superior colliculus. That's where the orientation is of the child who's turning towards the mother is turning towards the child, that orientation, and that plays a role in how this damage is done. If that, I don't, that may be a very clumsy way of describing it. And then the third part, and I'm just kind of going through my understanding of it, is see if you can correct me about it. Then it's the PAG, right? Help me out. Posterior periaqueductal gray, right? And that's the threat and effective response that happens then, and that's where you either activate the amygdala or you deactivate, or both, or you deactivate the cortex, right? Because the PAG is all doing that parasympathetic work. Am I getting this? Of actually keeping the person alive and safe and so on. And so it's turning off all the thought processes. And this would be a way of explaining why talk therapy doesn't work.
Okay, so yes, let me go at it maybe in a little bit clear. I don't know if this would be more clear.
Yeah.
The very first shock that Frank Corrigan was interested in was attachment shock. And since I don't know how much it related to his interest or if there was a trend happening already, but the whole field of developmental trauma has turned on that particular pivot toward attachment shock as being the core issue in developmental trauma. So attachment failure, attachment rupture, and the way that that's the psychological or dyadic or the way of being thought about. But Frank is taking this to the level of the brain, and at the level of the brain, when the baby's born, even in utero, the baby can turn its head and raise its arms. It can do that because of the superior colliculus. That's what the superior colliculus, what allows the motion of the head and the raising of the arms. So the baby, just by programming, by survival programming, turns toward the mother. And if the mother turns toward the baby, things are good. The baby is safe, and all the other things that can happen in life happen, but they happen in a dyadic formation, mother and baby. And the father is obviously extremely important too, but the core dance early on is the mother and the baby. So there's the attachment shock, and what we're trying to do is repair that so that people can turn toward relationships. Otherwise, they get scared to turn toward relationships. They stay isolated and dangerous often to themselves and others because we are social creatures. We are meant to be social. So the therapy that is called deep brain reorienting, I heard Frank describe it as a talk therapy that has no talking or very little talking. There's not much talk in DBR. It's primarily a neurology, as a way into the neurology of the superior colliculus through the muscles in the neck, the muscles around the eyes, and the muscles in the forehead, all of which respond to shock. And for most people with developmental trauma, attachment shock is not the whole story. It's that loss of the mother allows the predators in, as it would in any animal system. You lose the mother, the baby is in great jeopardy. So, but you can have, as a result of that history, as Frank calls them files, you can have multiple shock files, which can take a long time to clear. They take longer the more reactivity they set up in the brain every time they're called upon. Right? Neurofeedback is the premier approach to quieting that reactivity in the nervous system. And that's why I want them to be used together. So I was talking with Frank about this not long ago, and I said, neurofeedback is crucial in all of this. He said, yes, neurofeedback allows people to live a life, right? So you may not get everywhere you need to go with neurofeedback, although we are trying, and we can talk about that too. But and we'll need to use DVR, and it's fascinating. Even if you need to use it, it's fascinating to explore those regions. But it's going. I think for most people with these histories, it's to be well advised that they use both of these approaches together. That's hardly available anywhere, and I always have trouble with this juncture in anything I'm talking about where there's great hope and there's hardly any place to find it. So we're working on that as fast as we can. Well,
yeah.
Is that clear?
That is, yes. Thank you. And I know that when you originally wrote the book, Neurofeedback in the Treatment of Developmental Trauma, the central kind of piece of this was the amygdala and the limbic system, right? And it was really about the affect. And my sense of it is that that's sort of where the neuroscience was at the time. This was before you understood that there was something that actually in the process of someone responding to a traumatic situation that there was something that happened before the amygdala gets triggered. Am I getting that right? Can you talk a little bit about how that change happened for you, of like realizing, oh, I was saying the amygdala, but what we're really talking about is the brainstem and in particular the locus coeruleus, the superior colliculus, and the periac of the brain.
The short answer to that is knowing Ruth Lanius and then meeting Frank Corrigan, and then my own experience in 2016, where one of the things that set this up correctly. One of the things that Frank Corrigan says is that as long as that shock is retained in the brainstem, the person is subject to regression or falling back into the original dilemma. So in 2016, that was exactly what I experienced with the election of Donald Trump. And so I started to listen to the shock hypothesis, because even I could steady my course through that 2-year period that followed, which was a very productive period in terms of my therapy, into my recovery, if there's such a word. But the main thing that I had to look, okay, so neurofeedback is really setting the course, it's helping me a great deal, but something got set off. And I was already beginning to write about the brainstem, but I didn't know its centrality at that point. So so I've learned a lot, and then there's a 10th anniversary edition of my book, and I have written a new preface, and that is both DBR and the brainstem figure, quite highly in that preface.
Yeah. And the coincidentally, perhaps, or maybe not so coincidentally, there's you've talked a lot about the Indian Ridge as a way to get access to that area of the brain. And I wonder if there is further evidence, or what your thoughts are today about how the Indian Ridge plays a role in neurofeedback with attention to the brainstem.
So we can't know where we are actually reaching the brain from a scalp placement. It's very hard to know. My assumption is that the geography of the scalp and the brain have some relationship to each other. So the original work, I started focusing on the Indian Ridge over 10 years ago. So at the time I was writing the book, but I was focusing on findings in the cerebellum. And it was a paper by Marty Teicher in Ruth's first book on trauma as an epidemic. And he and Kārl Andersen were talking about how there was excess blood flow in the vermis, the central structure of the cerebellum. So I looked up where that is in the brain and put the electrode there at the Indian Ridge, which people tried to argue with me could not be an active site. I don't know why they think that any site in the brain is not active, because they all are. They all have EEG, which is what we're going to decide is the signature of activity in that part of the brain. And it is its own signature. It's got its own, it's often much more robust than 𝘲𝑝𝘂, for instance, which is considered a true site. This is a true site. And so, and in fact, it seems to have been quite useful at very low frequencies in helping people move out of the PAG, the threat position, in developmental trauma, the fearful position. As you know, that's what I have been. The subtitle of my book is Calming the Fear-Driven Brain, which I had always wished was the title of the book, because that's really what matters. And so whether it was the cerebellum I'm reaching or the brainstem I'm reaching, it's a little hard to know. But what we do know is that they're calming down. And what I think that Ruth's lab is finding, Ruth Lannis's lab is finding, is that in some way that I don't know, but that deep brain reorienting, which is showing very positive results in the brain, is a lot of it's affecting the cerebellum. So it may not be the brainstem, may be reaching the cerebellum because it's big and it's back there, but it's doing the job and through some reciprocal process. So yeah, so I have been working, at least indirectly, with the brainstem, investigating that for quite a while. And also the temporal parietal junction, which is a part of the brain which is a hub, and it shows up in derealization, depersonalization, dissociation, out-of-body experience, feeling you're not real, all of the things which are a concern to people with developmental trauma, with many people, those histories. So we are moving our attention, our interest, we as a group anyway, within EEGer, to the back of the head, and to seeing what we can do to quiet reactivity where it begins.
Interesting. So, and yeah, and that really brings clearly the awkward sort of transition between neurofeedback and DBR. What would you say for folks who are either approaching this from having learned to do DBR in their practice but not neurofeedback, or having learned to do neurofeedback but not DBR? What should people know about this combination of modalities?
Well, I think it's a marriage at the brainstem. I think we are approaching the shock file, or the shock retention of the brainstem, which would retain what has shocked it for survival purposes, without much discrimination. Survival or no survival is essential. The condition, the brainstem. And that when shock goes untreated, this is going to be my talk actually in Australia, when shock goes untreated, what happens is kindling in the brain. So these raw affects, not only do they amplify the raw affects, but they set up reverberation of affect. And in that, the person becomes swamped and they become, quote, untreatable. Well, I think all of the things now that we're looking at suggest that they are highly treatable if we can treat the shock and we can treat the kindling. We need to treat both. And in most cases, I think we're going to need to treat both. But when we can, when we do, we can get some excellent relief of suffering, right? Relief of suffering. And as Frank said, that capacity to live a life.
Great. It's interesting, and this is also part of the Trauma 24, the conference from last October, and during Frank's lecture, Dr. Corrigan's lecture, he talks about how part of what DBR is addressing is blockages to the body's natural process of clearing these shocks and this stuff. And so it's this way of understanding what trauma looks like, that trauma is in fact, one way of looking at it would be that it's actually just a blockage, an obstacle from, between what the body naturally is going to do. And he talks about the way of addressing that is to slow down the process. I wonder if you can talk a little bit about how, because I think this is some of what is challenging about this is that it is such a promise, right? This idea, it comes across as a promise that oh, your body wants to be better regulated. It wants to be in tune with in its relationships with other people. It wants to be well attached. And really what we're talking about is providing a means to actually guide the body to open up that file and let go of all of these things that's holding it back. I wonder if you could talk about that a little bit.
It's very interesting. When I first learned about the brainstem, and probably way before I ever applied this to anything that we're talking about today, I was taught that the brainstem is the least plastic part of the brain because it has absolutely to do with survival, with breathing and reproduction and sleep, and so fundamental activities that maintain life, breathing. So you can't, it wouldn't serve to have it be a very plastic area, unlike the cortex, which is all learning takes place, is plasticity, right? So everyone buys that. And then, and now we're talking about therapies for the non-plastic brainstem, and nothing can change unless it's plastic. But what are we finding? We're finding with neurofeedback and with DBR that it's highly plastic. And there would be no reason to know that, I think, no reason to suspect that before neurofeedback and DBR. So we're at a point of explosive discovery in that area of plasticity, I think, in the brainstem. Peter Levine has been one of the people, the author of Waking the Tiger, somatic experiencing, talking about the body and the body's inherent ability to heal itself, and that these the overtaking of by terror, essentially by the fact that you could lose your life or sanity, blocks that healing. And if we can find our way to quieting that reactivity, then the body will heal itself. It's not so straightforward because the shock has been so great. That's where DBR comes in, right? The shock of the car accident that's, that's its own thing. The shock of having your mother turn away from you that's the whole card game, right? That's everything, right? Now it's just somebody else, but still, it's the mother and your rhythm that matter. Okay. 𝘁𝗿𝗄𝗏𝗪, the neurofeedback whiz kid, said that the brain is devoted to its own regulation. It has to be. That's a perfect quote. It's exactly right. So what we have to do is find the way to help the brain learn to regulate itself. And once it does, it will do that. It does that. But the essential sort of take-home point is that we've been treating the mind, and we need to treat the brain. And when we treat the brain, another mind is possible. A traumatized mind is given rise to from a traumatized brain. And both Frank's approach and deep brain reorienting and neurofeedback are the ways to go with treating the traumatized brain.
Yeah. So this piece of it, of addressing the so-called non-plastic part of the brainstem, which used to be called the reptilian brain, right? Like, and I grew up learning that this was the part where it's all unconscious, like you have no control over whatever. And of course, anybody who's done biofeedback knows that if you get some awareness of what your heart rate is and so on, you can have some influence over that kind of thing. But this goes even further than that and says, by having this conversation with somebody who is a skilled DBR therapist, you can access the instance when you experience this shock. You can slow down enough to actually go through that process and do that, allow your body to go through that process. And it's not explicitly conscious, but it's not happening on an unconscious level either. Exactly. It's what's interesting partly to me about this is that in some ways it challenges the very idea of how we think about memory, right? Like how we think about what actually happened at a certain point. I wonder if you can talk about in the work that you've been doing, like how that whole framework of like the way that we think about episodic, or these kind of this way of looking at things that happened to us in the past, that is kind of necessarily under review, right?
Oh, it's necessarily under review, big time. Yeah, it is. So I don't think there's been a turn. In trauma land, we talk about the difference between remembering and reliving. And that as soon as you're in reliving, you're in trouble, right? So you don't know you're not in the time of the trauma. You don't know that you're not a little kid, or you really don't know it. You may have some trace idea that you're actually at a coffee shop buying your own coffee, right? But if the trauma hits you at that point, that is a very hard negotiation. This is just real. This is what happened. And that moment is going to be the coffee shop moment. Let's say something happens, something that is significant to the brain, and that shock file can open. Okay, and that's what's happening with traumatic memory. So the way that it, for me anyway, in the experiences that I've had with DBR, the memory comes up a little bit like a Polaroid photograph. It's not in the senses really, except in the set of visual representation. It's not reliving, and it's not remembering in any way that I've ever thought of using those words. It's something else. We don't have a word for it. I don't think there's a word for it, at least yet. But it rises up, and when it's happened for me, I usually double check and triple check, and still there, it's still forming. And then I'll say something, and then I either know or don't know that it happened. And not only will I know that it happened, well, I'll give you one relatively benign example where I was pushed over from a sitting position as an infant. So you're just learning to sit up, and I got pushed over. Well, I realized in the whole, whatever way this happens, that I had been pushed over, but by my brother, who didn't intend to push me over. So not only did I get the memory itself and the hit on the back of the head, I remembered that, but I got the whole field of intentionality with it. And I think most people talk that happens for them too with DBR. And there's some very dramatic examples of that. And it can make all the difference what the intentionality of the other was, right? So in terms of your letting go of something or it being let go of, I mean, who's letting go? I don't know, right? This is brainstem. It's no longer needs that file. It's done. I don't know. I mean, there's a little mystery here, right? Quite a bit of mystery, but it works, and it is affecting the brainstem and the orienting tension, which is the musculature that forms up in response to the shock, the activating stimulus, which is something approaching the shock. Those are the muscles that are directly reflective of the superior colliculus. The head being able to turn, and the startle, that the eyes being able to open wide, or close or open wide, depending on what you need for the situation. The head coming up, and the forehead getting tense. So you just imagine you're walking in the woods and you see a deer, and you startle the deer. That's exactly what the deer does. The head goes up, the eyes wide open, the forehead is supporting all of that. That's just the way the anatomy works, but it's given Frank just followed this, and it's given him and people who do DBR access to these non-conscious memories.
Yeah.
Jung thought that the brainstem was likely to be the physiology, the psychophysiology of the unconscious. He names that. So Freud seemed to also have interest in brainstem. So even very early on, there was, some intimation that the brainstem is going to become important. Well, it's descending. Now, when I find out that it's, I don't know, somewhere else. But right now, I think from my point of view, feedback should be focused on the brainstem, and therapy should be focused on the brainstem. And the only brainstem therapy that I know about that I think takes shock into account, and that's the core issue for the brainstem, is DBR.
Yeah. My sense of it, having been part of a number of the DBR levels 1, 2, and 3 trainings, is that it can be an extremely challenging process for folks who have worked in the therapeutic field as mental health professionals for a long time to understand, because it's kind of a change in approach in how you are being there for a client. And I wonder if you could talk a little bit about what that presence, what that means, how that changes from the sort of attachment frame of being a therapist who is modeling what positive attachment looks like, to being someone who is there, present with the person who is, and I guess my sense of it is from just watching Dr. Corrigan, as in the process of the ways in which, when he chooses to say something and when he chooses to say almost nothing, and the person feels the presence. I wonder if you could talk about would somebody go about making that, if someone is interested in doing DVR, what are the kinds of changes that we're talking about?
Oh, for some, they're going to be major changes. For other people, it'll be trusting their own approaches, that their own being, their own presence. And I think, I do think a lot about the nature of this presence is. It's non-intrusive. It's warm. There's always kindness and there's patience. Can sometimes be directive, but it pretty much keeps the therapist's unconscious out of the picture. You're listening for shock, and you're helping people process, and you're looking for it because there can be startle responses of different kinds in the body. You're looking for that, asking about it, and you're helping people get to the moment before the shock happened. And that's the goal. It's not fancy in a certain way. It's just not always easy to identify those moments. That's training. That's training and practice. It is, for those of us who are curious about psychic processes, well, this is a very fascinating thing in and of itself, this approach to the brainstem. But you don't end up asking a lot of questions about what happened in your childhood, and all in all, you're really going for the shock. And one of the reasons that Frank's consults are so wonderful is because people don't need to tell a lot of history of their patients, right? They just need to talk about what happened in the session, and Frank can help guide them on where they may have lost this thread of shock. And that's what you're always looking for, and you're always looking to disperse. The way that neurofeedback comes in here is that a shock reactivity, we can quiet that down. People are less afraid of their own, what's in store, as it were. Less afraid in general, more functional, sleeping better, eating better, all those things that the more general regulation of a dysregulated system allows.
Yep. Yeah, that's great. And it occurs to me that it couldn't be a better time for this therapy to be becoming popular, because it seems to me, I heard in a consult session recently, someone was talking about the number of people who they were coming to them for help that were experiencing, levels of shock in just reading the news and just watching kind of what is happening in the public social sphere. And so it strikes me that this is a time when an understanding of what that shock looks like and feels like, and what the implications are, what the consequences of that are, that it's extremely timely. I wonder, in terms of, I guess on the one hand, there is this sense of like real possibility here, in terms of like how, we've always approached this from an individual kind of, we are one by one, we're drawing people, the work that we do at EEGer is to support the clinicians who are helping people to better navigate their lives and actually, confront some of their history and the kinds of things that are really difficult for them to deal with. But it's now on kind of a social scale. It's even broader than that. And I wonder if you can speculate a little bit, if you dare, about
Carol. Yes, Carol. EEG alert. Yeah.
Right. Because it just seems like there is that, on the one hand, this deep promise of like what we now have a renewed understanding, or a new understanding really in the last 10 years of kind of what is happening when there is shock. And I don't know where does that take you in terms of like what we can look forward to in terms of what therapists should be planning, should be thinking about, should be envisioning for the future, having
Well,
been involved in this from the beginning.
the very first thing that I think therapists need to figure out is how to take care of themselves and their own nervous systems, because everyone's shot. They're all, experiencing the rough and tumble of the politics of the day. But it's not even the politics per se. There is at least an analogy between the individual attachment rupture and the lack of regulation as a result of attachment rupture that leads to all kinds of diagnoses that is replicated in our political situation today. You would have a sense of being cared for, even if you had individual gripes and there was not enough freedom, or there was, all of the different things that anybody could feel, but you had a general feeling of being cared for. And I think that started to, the complexities around that, and each individual voter, that's a whole, that's beyond our scope. But the general feeling of being taken care of, you are either feeling taken care of by your government, or you're not feeling taken care of by the government. And that's an attachment dilemma. And to my point of view, presently, we are being governed by people who have failed attachments by documentation. And so that's and they don't know what they're doing. They're not in relationship, an empathic relationship in their lives, generally speaking. They don't have a sense of caring for the other. That's not the norm. It may never have been the norm in politics in general. There's all kinds of, they're just people in there. But the people now that have got the podium, as it were, I think are very well suffering these kinds of attachment shocks themselves. And one of the outcomes of that can be that something called primary process lying, where people just say things. In attachment literature with kids, with foster kids, this is often in foster kids. So you'll have a foster kid in your home, and you have said they can have no more cookies, and you see them go and get another cookie, and you say, I told you no more cookies. He said, I didn't have to take another cookie. But I just saw you take it. I was standing right here. I saw you. He said, no, I didn't take it. That sounded all familiar to what's going on. It's like, it's like, and you have the feeling, it's very eerie. You have the feeling when you're with a kid like that there's no ground to stand on, because there's no shared reality, right? And that's a problem in their brain. That's a fundamental problem in the default mode network. And that's what I think we're dealing with writ large. And the kid doesn't really, in that situation, doesn't really know they're lying. They don't have the interpersonal reality, right? So I think of it at least in that realm. I don't think that's an adequate analysis, but from our point of view as therapists, our patients are more traumatized, therapists are more traumatized. This is not a protective environment. I think even people who voted for the present administration are starting to feel unprotected. That's chaotic. That leads to lawlessness. So we need to be, we're not going to be able to, I wish there was such a possibility of social engineering that we could help people in big ways, but I think it's individual. I think it's always, Buddhism is individual, meditation is individual, spirituality is individual, coming to terms with your history is individual. Everything is on the individual basis. And in that regard, we have a great deal of hope that we can help people. Bessel wants neurofeedback in the school system? Was it in the school system to allow children to learn non-reactivity? If you were looking for any quality that would be welcome in the world today, it would be non-reactivity. Left, right, middle, doesn't matter, where you are. The less reactive, the more productive. And we are in a time of setting off reactions everywhere, and it's dangerous. It's dangerous.
That's great. Thank you. I wonder, taking it back to sort of the realm that I feel more comfortable with, which is sort of the more conceptual understanding of how things are. There was one part of the introduction to Trauma 24, to the conference, where you talked about how we call it mental illness, but it's neither mental nor is it illness. And I wonder, I just love that as a starting point, because this idea that all of the dysfunctional behaviors and perceptions that people come with are actually a response to an intolerable situation, right? We call them illnesses as if it somehow is this essentialist piece of like it belongs to that person, but in fact it's just a person's response to a difficult situation. And then the other piece is the one that we've kind of talked about here, about it being, it's not mental. And I wonder if you could talk a little bit about that whole sense of like, I think part of the challenging thing is really going against this Cartesian idea that all of these issues are finally psychological. It's not an embodied brain level, it's not within the human body or whatever. So I know that's a big question or topic for 10 more minutes, but I just am curious if you could expand on this idea of like that it's neither mental nor is it illness.
Well, it's a punchline, right? It's a way to get people's attention. That's the first reason to say it, but it's also true. What we are, it's the whole thrust of the conversation, and what we need to be thinking about is what's happening in the brain. It's the brain's response to intolerable situations, personal situations in childhood, typically the most damaging before the age of 7, right? So, but the brains build habits and they perpetuate what they've learned. That's what brains do. So so we have to take the focus off the psychological or the mind per se. It's a very hard things to tease out, and I'm not Cartesian in that sense. But the mind and the brain are hard to differentiate, and I hear neuroscientists using mind and brain interchangeably. It's just not accurate. So when I say it's not mental, it's to say the brain has engaged in its own survival pattern, right? That's the illness part, right? And but the mental part is just the brain, and then it's the fact that it's not illness. It's the brain's alignment with the circumstances of its own survival. Now, those are not serving survival. But at one point they did, or they just wouldn't be there. This is such a destigmatizing way to look at the issues of what borderline personality and, all the personality disorders, narcissistic, all of them. You start to look at the fact that this brain is, has done its best to survive some challenging early circumstances. It's learned, it has bad habits. You could even think of it as having bad habits. And we can teach the brain through neurofeedback to change those habits, to quiet the reactivity. If we look at neurofeedback, it's one most important way for me is to quiet fear, quiet reactivity. That's the most important thing for every individual, whether they have a developmental trauma or not. But with developmental trauma, that's taking over. So to quiet the reactivity, and then we find that, oh, there's this thing left over when we quiet reactivity waiting to spring, right? And that's shock. So how do we take care of shock? That's where we bring DBR together with neurofeedback, and that's what we talked about in Trauma 24 with Ruth and 𝙗𝗂𝗿𝙃𝗀𝗏𝙀 Sands, who's the other co-developer of DBR, with Frank and me and Helena Bester and Andrew, and we all talked, Andrew Nicholson, we all talked about these issues. It's a robust and fascinating conversation.
That's great. Thank you. Yeah. I wonder, is there anything else that you would like to leave folks with? Thank you for having this conversation with me today, Sebern. And if you have any other thoughts about sort of what's coming up with the summit in Australia that you're going to, and what folks can look forward to.
At both these conferences, Trauma 24 and in South Africa, and the conference in Australia, people have access to and either in person or online to Frank Corrigan. We'll watch a he did a demo. Watch him demonstrate DBR is the way to learn. You'll really begin to learn what to do with watching him. 𝙗𝗂𝗿𝗃𝗀𝗏𝗃𝗀𝗃 Sands, who looks at the developmental issues in DBR, how the brain forms from in regards particularly to connection and attachment. To the leading researcher in the field of developmental trauma and dissociation with Lanius, as she will be online in real time. And I'll be there, and I talk a great deal, as you know, as I have already, talk a great deal about the place of neurofeedback and quieting reactivity of a nervous system that has learned, that is responding to its shock, but has learned that, and perpetuates that in a kind of kindling response. And I'm going to talk more than I ever have, really, about the kindling response as we go into the Australia summit.
That's great. Thank you. Well, I hope that it's a wonderful trip, and you'll be reunited with a bunch of people that you know going back years. So that will be really fun and nice.
You know, Lars, the other thing is that I think that Kyle may be on something really important. And if that turns out to be at least even 80% of the time that 0.02 in sub-hertz does what I had it on, because I haven't had it set up for sub-hertz yet. I was doing it on Signet, and it was it's been remarkable what's changed in the 2 weeks since I started doing that, or 3 weeks. And you start to think that it's not like I think to myself, well, there's nothing more you can change, right? In this perfection, I always think there's things that I can change, but I don't expect change so late in my life, and so after so much neurofeedback. And yet, guess what? Yeah. Change. Really, really non-dramatic, but that's the important part. It was non-dramatic and persuasive. So, so we're just starting, right? We're just getting there. Very wonderful.
Thanks for watching. If you found something helpful, use the like and subscribe. It helps us with YouTube algorithm and lets us know we're on the right track.